So I'm sure you enjoyed together with me 3 presentations coming from different directions, disciplinary directions, philosophy, the legal, and the social science. But I think it was also interesting to see that despite the fact that they were coming from different directions, some of the themes kept up rising, and I'm sure Aeyal and Colleen are ready to respond or to add their comments and perspectives. I'll present them, although by now you're familiar with their work at least. Aeyal will begin, but I'll start with Colleen, presenting Colleen. So Professor Colleen Flood is Professor of Law at the University of Toronto and has a cross appointment also in the Department of Health Policy and the School of Public Policy. She was Canada Research Chair in Health Law and Policy and was a Scientific Director of the Canadian Institute of Health Research at the Institute of Health Service and Policy Research. And this is just to point the experience that she brings to the table from the field of studying these questions. She's she's the editor of numerous books. This is number 9, I think, on your list. Several of them have dealt with related issues, but none of them are actually done this kind of international comparative work. Thank you for being here with us. And Aeyal will begin. Professor Aeyal Gross, who is familiar, I'm sure, to all of you. Still, I'll say, an expert in international law, has written quite a bit about gender and queer theory, but I think has become in recent years an authority on questions of health law, and has written about these questions from different angles, including in the context of the welfare state. Aeyal, please.
I want to start with the most important part, which is thanks. Some of them are written in the book, so I'll just not want to forget anyone. So first of all, thanks for you all for coming. I want to thank, as we worked on this project for a few years, so first of all, I want to thank Colleen for the collaboration. You mentioned the metaphor of the marriage from here, so I will say there was, because of what Daphne said, of a bit of marriage of me coming from constitutional law and international, and Colleen coming from administrative law. So actually this is reflected in the book, and me coming originally more from human rights and Colleen from health economy. So we also a little bit, and I think in what you all mentioned, it's reflected that, and I think it was in that sense a good marriage of people coming from different direction to this area, so of course thanks to the University of Toronto. Actually, Colleen recently moved to University of Ottawa to update your bio, but this work was done with the University of Toronto, and I want to thank a lot of people there, especially Brian Thomas, who did amazing work with us. And here at Tel Aviv, I want to thank Sharon Bassan, who is here, who worked as research assistant on this project for quite a long time. And then Shai, in your previous capacity as the head of the Minerva Center, which organized the workshop here last time, and Daphne, being dean at the time, who supported this project. And in addition, and of course the Safra Center, Shai and Chagai, where's Chagai? And Limor, and they did, I think especially Chagai, a lot of work on this and on the conference. And I also want to thank, in addition to all of those, 2 institutions that helped me a lot, the Israel National Institute for Health Policy Research, which gave a grant, and then the Joseph H. Flom Global Health and Human Rights Fellowship at Harvard Law School, that without those 2 institutions and their support and funding, it wouldn't have been impossible. So that's as far as the thanks. I think, especially actually Guy already went through the typology, so I just, I won't waste your time with this. But going to what Norman said about that the right to health matters, and the different roles in play in different contexts, which you all made, and I think that what we tried to look at and what we concluded was that it matters, but maybe not always in the way that we think, and it matters differently in different places. As Guy mentioned, we looked at different reasons for the rise of the turn to right to health, which was in the Covenant, in the Universal Declaration, but kind of dormant. But then we see the end of the Cold War and the sort of end of the ideological divide that each of the blocs held to one set of rights. The human rights movement, which seeks to remain relevant in times of poverty, the growth in demand because of development in technology, growth of population, and aging of the population. On one hand, on the other hand, the reduction in the ability or the will to give, partly because of the neoliberal ideology and the Washington consensus, the pressure to cut public expenses, the globalization of trade, and especially TRIPS and the effect on property, intellectual property rights, which had potentially, or not just potentially, detrimental effect on access to pharmaceuticals, especially in the context of AIDS. And then some healthcare reforms in different countries, including the one we are mentioning 20 years today, healthcare reform which seek to control cost, volume, and quality of the healthcare that in many countries that Colleen wrote, I think, her first book about, and this causes a lot of litigation, democratization and new constitutions, which include social economic rights, and then the issue of AIDS, which Guy expanded upon. All of those we identified as reasons for the growing turn to right to health and litigation. And I think when we divided the countries into the different categories, and we can see here as the health expenditure, the public and private division of the health expenditure, and life expectancy. And Sharon, you worked once on those charts for a long time to collect this data. So and as already mentioned, but I'll just go over it briefly. We see very different role for the right to health in those countries, and even as Guy rightly mentioned, among them, because for example the UK he's different than the others. Within those countries, generally no enforceable right to health, despite or because of a well-established health system. On the other hand, today those countries are also facing growing demand on one hand and diminished capacity or willingness to give, and that creates the need to prioritization, rationing, and selectiveness. And those are being we see attempts to challenge those decisions without a constitutional framework. Often with relatively little litigation. Sweden, New Zealand, very few cases. Canada, risk of rights as being part of privatization, which maybe we'll talk about shortly. And then UK, and where the administrative law model is very strong. And then going to the relationship between the global and the local. And Guy, I want to say that we're very concerned about, is it right to do a book that does state comparison about an issue which is so global? And hopefully, as you say, we fill this gap in the introduction, conclusion, but also within the chapters themselves. And the EU has a specific resonance here, where EU, where the ability, the Daphne you mentioned, to travel between countries is even stronger, or the strongest, is maybe changing the picture because people are going, because of the need to create one standard, and actually the place where we see most success maybe for litigation is relying on EU law within some of those countries. And then moving to the social health insurance managed competition model, unlike those countries which are all high-income countries, those countries are all high-income countries except for Colombia, which is middle income. And we can do a lot of interesting analysis about the relationship, but we can see that here the relationship between public and private expenditure is strongly in favor of public. Colleen, I'm a bit worried about what Canada here. And we see that here it's already getting lower. The relationship between public and private, we see more place for private finance, even it's still about 50%. We see, and we see that in those countries, we have the triad of relationship. The third parties, insurers, versus the first model. We see a very complicated process of, on one hand, expansion to universal healthcare, while privatization, managed competition, sometimes by non-profits, sometimes by for-profits, but even when it does for non-profits, as we very well known in Israel, the universalization comes together with partial privatization of the financing through co-payments, and the triad of patient, provider, and state, and the defined health basket as part of the model of an insurance, which is different than the tax-based system, is conducive to litigation, often against insurers and providers, but also against the state health policy. And finally, the mixed private-public model, all of the middle-income countries, except for the US, where we see that already, except for China, which is on the border, in all of those countries, it's mostly private expenditure rather than public. Sometimes also the life expectancy is very troubling, sometimes because of HIV, like in South Africa. And then we see here more likely to find constitutional right to healthcare or derived from other rights. In some countries, courts open the doors, and then there is a risk of what Norman, you talked about, those telescopic judgments that you look in the individual cases like Brazil. In others, there are collective cases like South Africa and India. And here I want to say that we do see those visible, but also sometimes the successful structural cases. And we actually are critical of we think that we should see more of those. Although there are limitations, as Daphne said, about how much court can change structurally, but we think that looking at structural situation of inequality or policies would create a less equitable healthcare system is something that courts maybe should address more. And then another thing, we talked about the different political system, health economy, economic system, legal system, health system, but we also have to talk about the independence of courts. So China, Nigeria, and Venezuela are all countries where actually I also said lack of judicial independence, especially in China and Nigeria, makes court ineffectual. And then there's a question whether litigation may threaten healthcare reform. US, now there's a second case. In the first case, the people attacking the litigation failed, but this month, the US Supreme Court will have to again decide whether the healthcare reform that tries to bring a little bit more health equity can. So this has to do again with a double-edged sword. And my attitude is always that rights is a double-edged sword. So it's a question: what do we do with them? I think that. Norman wrote that we may. He wrote in his really excellent book, superb book, Just Health, that we may claim a right to healthcare only if it can be harvested for an acceptable general theory of distributive justice, or from a more particular theory of justice for health and healthcare that will tell us which kinds of right claims are legitimate. And in a way, we try to, after you said that maybe it can show that maybe you're reprimanded, not at all. I think that you actually made the conceptual argument, which is very smart, that not every argument. So, for example, when people make the argument they made successfully in Canada and failed to make in Israel, that rights to certain private services are part of the right to healthcare, that would, under your conceptualization should be rejected. Unfortunately, courts do not always follow your conceptualization or our understanding of rights that should be anchored in concept of distributive justice. So just to, so I want to thank you all for your really, I think, very thoughtful remarks about the book. To conclude, Norman, regarding what you said, yeah, it matters. I think it does matter, but not always in the way we think. And we try to look into different contexts. And I just want to say, Daphne, what you said, I was thinking, because as quite a lot of people here know and some are involved, I've been kind of a little bit doing now, whether in addition to work on right to health, work on right to food and food security. And it's really interesting because unlike the situations, how harder it is in a way, because you talk about the bureaucratic systems of healthcare, education, and welfare, where actually we want to get the service from the state, and we're talking about, and then I think it's interesting to compare another social right, which is so different, because normally we don't want direct provision from the state, and the question of the bureaucracy is there sometimes about, like in schools when they give out food, but it's interesting to also look within the social right between the one which depend on the, to a large extent on bureaucratic structure, especially when it regards to the access to healthcare. Not in the regards to the social determinants of health, etc., but and other social rights, and maybe the food is the one that I'm thinking about mostly now, but maybe we can think of others too, where the story is very different, and it's much harder to compare the right to food than health, which is comparable to education and to welfare. So, and I think that everything that now it seems to me like health is easy compared to. Okay, so those will be my short comments. Once again, thank you all for coming, and I'll give the floor to Colleen. Thank you.